microphone here. All right, so I think we're going to get started. I know it's a gorgeous day. We were thinking that people, what's that? Oh no, I didn't turn it off. All right, yeah, that sounds better. Okay, so we're going to get started. We may have some other people trickle in. Might take people a few minutes to get in today. But I wanted to first start by asking if there are any questions from last session about writing a research question or things that came to mind afterwards that you wanted clarification on, or no? All right. So today we're going to talk about study designs. And when I was walking up here, when I was in the elevator, I thought, this is one of my favorite topics, but it actually isn't, because when we get to secondary data analysis in 2 weeks, I'm probably going to say that again, but then when we get to statistical analyses, that's really my passion. So this is one of my favorite topics, I will say that. And as you can see, Allie's not here today. She had to, she couldn't be here, but she's planning on being at the next session. So we're off next week for PAS because most of us are going to be away in Boston at Pediatric Academic Society annual meeting. And then we'll reconvene the following Monday and talk about secondary data analysis sources. So what we're going to do today is talk about study design. So what I'm going to share with you is some major considerations for choosing a study design and compare. So really, there's no perfect study design, right? But it's what's most ideal for your particular research question. So we're going to compare the relative merits of each one, because each has different strengths and limitations. And then we'll end with a practical example. So we'll move from what we talked about last week in terms of your study research questions or outcomes research questions, what kind of study design would be most appropriate to choose. So just to reorient you, and for folks who weren't at the first couple of sessions, this is sort of the map of where we're going with the seminar series. So we talked last week in the first couple sessions about writing a study question, writing a testable, generalizable, relevant study question. And now we're going to move on to what do you do from here? You have your study question. What kind of design would you choose to answer that most appropriately? And so this is kind of where we're going today. So we're going to choose the type of study design and the particular method. So what I'm going to focus on are the ones that are in yellow here. So there are also research reviews, which are essentially case studies or compilations of case studies, which are important to outcomes research as a starting block. If you have a particularly unique patient or patient experience, writing up a case study, compiling different case studies and that. We're not going to talk about that today, but I know there's been a lot of interest in folks writing case studies, and we're happy to talk with you about that if you want some guidance around writing a case study. We're happy to help with that. Next session, we'll talk in a lot more detail about secondary data analysis. So what it is, some major secondary data analysis sources for pediatric outcomes research. We're not going to talk at all about qualitative methods. CORE has an entire qualitative methods seminar series that I encourage you, if there's information about it on the website, on the CORE website. But if that's something that you're interested in learning more about in terms of qualitative methods, I strongly encourage you to attend that. It's fabulous. What do you mean by that? What do I mean by qualitative? So things like focus groups, interviews, one-on-one interviews, mostly focus groups, and using qualitative data. So a lot of, picking out keywords and things and looking for themes, as opposed to some of the topics that we're going to talk about today. And so in terms of more quantitative methods, not that qualitative research doesn't include quantitative methods, of course, but the more quantitative study designs that I think of are things like randomized clinical trials and pragmatic trials. So we'll talk about these today: quasi-experimental designs, survey research, program evaluation, and a cohort or longitudinal study. So these, am I correct in assuming that these are the kinds of things, types of research study designs that you might think about implementing in your clinic or program?
What do you mean by program evaluation?
So I'm going to talk more specifically about that. What I typically mean is, if you're running a program and you want to know, does this program work? So you have your set of outcomes. You have maybe, so I'm going to give you an example using asthma action plans, and we're going to walk through each of these. But essentially, if you had, you were part of a pulmonary clinic or a primary care practice, and you implemented a program about asthma action plans and then want to know at the end of the day, does this make a difference on a variety of outcomes? So usually program evaluation it's unique in the sense that you not only have the components of it in terms of the outcomes, but you're also very interested in process measures, right? Because you want to know, what's happening along the way. Are the kids getting the intervention that in the way that we originally wanted them to? So you include not only the sort of outcome measures, but also the process measures along the way. So what we're going to talk about is some of the threats to validity for each of these, because they all have sort of varying degrees of threats to validity. Some, more concerning than others. And then, like I said, no study design is perfect, right? So they all have relative strengths and limitations. So we'll talk about some of those and some of the things to consider for your particular clinical area and research question. So just to orient us again about this hierarchy of evidence, for those of you who didn't see, I don't know if I'm touching. No. Okay, sorry about the static. I can. The problem is I probably shouldn't say this. I would think I have these like maternity pants that are hard to, they don't really clip. They have so not really. Maybe they can edit that part out. Oh yeah, maybe that's a better idea, like a pager. You can edit that part out, right, about the...
I don't know, I'm good, but that would be tight. If it keeps doing it, we'll just switch to this other.
Okay, all right. All right, sorry about that. Okay, so just to orient us to the hierarchy of evidence. So this is from Agency for Healthcare Research and Quality, AHRQ. And so I bring this up. Somebody had a question. I think you had a question about comparative effectiveness and using observational data. So there was a whole AHRQ conference about that. So you might want to check out the website here. And is it okay on your slides? Okay, so if you're interested, there's a whole panel dedicated to comparative effectiveness research and using observational data. And so essentially, where they first started was this hierarchy of evidence. So what we're going to focus on today is pretty much the top of the pyramid, the second and third sort of tiers of the pyramid, with randomized clinical trials, controlled clinical trials, and observational studies. That's pretty much where outcomes research generally falls and what we'll be using as examples today. Down here are things like case reports, case series, uncontrolled observational studies. But just to kind of orient you again, we have this idea on the axis of bias and applicability. Right? So the higher we get up towards, meta-analyses of really controlled clinical trials, we have very low bias, right? We have a lot of internal validity. Down here, of course, with case reports, we have a lot of bias. Okay? However, when we think about generalizability and applicability to patient populations, maybe I should switch this out, do you think? All right, sorry about that. Is it me, do you think?
No.
Okay.
It sounds like you're getting it outside of the
Okay. All right. So that should be, all right, I'm just going to hold it then. Okay, so we're always in this balance, right, of external validity and generalizability, who this is relevant for, who we can apply it to. And we somehow have to strike a good balance between our internal and external validity, and I'll talk a lot more about that. And this, is going to have a lot of implications for sample size, cost, time, and so forth. All right, so we're going to think about these study designs, and we're going to root it in an actual example. So do children who have an asthma action plan have fewer asthma-related emergency department visits than children who don't have an asthma action plan or asthma clinical pathway? And so our decision, let's just assume that that's our research question. We have a choice about whether we're going to use available data, which is secondary data analysis, data that's already been collected, or we're going to go out and collect data on our own. Okay? And so what type of study design might you consider to answer this question? So what we're going to do is walk through each of these examples, an RCT, pragmatic trial, quasi-experimental design, survey research, program evaluation, and a longitudinal or cohort study to see what that might look like to answer this question. Okay? And then we're going to talk about what some of the strengths and limitations of each of these approaches are with regard to this balance between internal and external validity, or bias and generalizability, time, cost, and the sample size required. Okay? So before we get going with that, I just wanted to say a couple more things about internal validity and what the sources of bias are and threats to internal validity, just so we're all sort of on the same page. A couple of them we've already highlighted in the previous seminars. But the first one is sort of the classic one, and it's called ambiguous temporal precedence. And essentially, that's not knowing which came first, right? So what you want is to measure your exposure and then measure your outcome, right? So when you measure them at the same time, you don't know which really came first. And oftentimes, there could be a reverse causation where the outcome actually caused the exposure, and you worry about that if you're attributing the outcome to the exposure when, in fact, it's the reverse. So understanding which variable came first, or more importantly, that the exposure came prior to the outcome, or your dependent variable. So we talked a little bit about that in the last couple weeks. Selection bias, we also talked about. And selection bias, those are systematic differences in respondent characteristics that are causing your observed effect. So the example that we talked about last week with the surgical outcomes, where we just look at our exposure, was whether or not you received the open procedure versus the laparoscopic procedure, and then looked at the outcome. If you didn't take into account the fact that kids who are sicker systematically get an open procedure, then you would be attributing the better outcomes for the lap to the fact that when really it was just that those kids were not as sick. Right? So we don't worry about random differences in acuity, but here we know that random differences are associated with the exposure. So that's what we mean by systematic, that there's a reason why that the kids get a certain procedure or not. So we call that selection bias. History is when events occur concurrently with your treatment. And so if you don't know about that and appropriately control for it, then you could be attributing your intervention to things that are just happening, in the world, right? So examples might be a new clinic opened, or insurance allowed greater access to behavioral health services, for example, or there was some other difference that happened. A new clinic was opened, or things that are completely outside of your particular intervention, but are associated with improvements. And so if you don't sort of control for those things that are happening outside, it can look like your treatment had an effect when in fact it was just sort of contextual factors. Maturation, we worry about this a lot with kids, right? Because it could be naturally occurring changes over time that are confused with treatment effects. So I'm doing a lot of work now thinking about developmental delays and sort of the natural progression and chronicity of development, and particularly of developmental delays in the first 3 years of life. And this is a big issue because we can show, if you do a program evaluation and show, well, access to early intervention means that, X percentage of these kids are going to improve, when in fact, most of those kids probably would have improved anyway because that's a natural developmental trajectory. So understanding sort of this maturation issue for outcomes research is particularly important if you don't take into account what would happen absent of the treatment. Okay, and so things like a control group can help with this, or doing some repeated study designs and pre and post measurements and so forth can help you get at answers some of these questions and reduce the bias associated with that. Questions about any of those before I move on to the next set? Pretty clear? Okay. So regression, this is something that is often called regression to the mean. For those economists and health services researchers tend to use that term. And it's when units are selected for their extreme scores. They often have less extreme scores on other variables. And so the classic example in the adult world is blood pressure, right? So if you measure blood pressure on your clinic sample, and if it's a clinic sample, they're probably going to have elevated blood pressure, and you're going to have a lot of people with outliers, especially if you're in a cardiac unit. And so really, there's no place for those people to go but down statistically, if you amass sort of a population of people. And so that's the concern, is that if you're choosing people on high extreme scores, so blood pressure is the classic example, but for me, if I choose people on extreme developmental scores, extreme meaning, extremely low in this case, most of those kids have nowhere to go but up. I mean, many of them will have persistent delays, but it's problematic to choose such extreme scores, because naturally what will happen over time, and as you get a bigger population, is that those kids will go toward the mean. They'll go toward the average score. And so what happens is, if you don't take that into account, the larger population you have, the more time you follow these kids, they're going to start to look better, because statistically that's what will happen. And so if you attribute that to your particular intervention, that can be problematic, and that's actually a bias, because what's really happening is just the kids are improving over time, or just moving towards where they typically would be, because that's what the mean is. Does that make sense? Okay. So attrition is systematic loss of respondents. So no study, you're probably never going to have 100% follow-up rate in your studies, right? And so what we worry about is if there are systematic differences in how people drop out of your study. And so systematic might be related to SES or acuity or access to services and things like that. So having good measures of everybody at baseline can be very, very helpful in that, because then you can sort of track who was lost, and you won't have information about them at the point that they're lost, but you'll at least have some baseline information, and there's some statistical techniques that you could do to help with that. I was part of a large study in Wisconsin that followed a regional cohort of babies born very low birth weight, and you can imagine, so the PI started out with almost 1,500 very low birth weight babies, and by the time the actual follow-up group at between ages 2 and 3 was about 700 babies. So we had lost, almost about half of the babies, which is very concerning from a statistical standpoint. But you can understand, so we lost a significant proportion of them because they died, because these are very medically fragile infants. Many of them were from low SES families and couldn't stay with the study. And so what we did was we had information about that, everybody, at the beginning. And so what we could do is come up with sort of a profile of the whole group and compare those characteristics to the characteristics of the kids that we had. And then there's fancy things you can do to weight the data to look at how much bias you're really introducing by just looking at the sample that you have. So my point here is that, we worry about attrition, but there are ways to get around it. And if you collect, very good data from the beginning, baseline characteristics of everybody. And again, that to reiterate last week's theme, it goes back to having a really solid research question and having a solid conceptual framework to know what you do need to measure and sort of worry about in your study, what might cause bias. Testing, I worry about this because of, I'm interested in developmental delays and so forth. So repeat exposures to the same test, and probably many of you who do sort of testing with kids, that's more sort of, psychological or developmental testing would worry about this. Or perhaps even some of the, not so much biomarkers, but kind of, other exams that kids get. But that exposure to the test can influence subsequent results. Okay, and so we worry about that again, because it can look like the treatment had an effect when it's just an artifact of the repeat testing on the kids. And similarly, instrumentation, the nature of the measure may change over time. So for example, the work that I was talking about with the dynamic chronicity of developmental delays, oftentimes, the same developmental exam is not appropriate for kids across all ages. So if I show that there's, a big drop-off in developmental delays or a big gain in developmental delays, and I'm not using the same measure between, let's just say, 24 months and 48 months, one could argue, well, it wasn't really the kids. It was just you were using different tests, and they weren't comparable, and they weren't sort of compatible in their psychometric properties, so that it's an artifact of the test versus what actually happened with the kids. And that can happen with any kind of test or instrumentation, not just developmental exams, biomarker exams, and so forth. This can be problematic. Questions about internal validity? No. Okay, so now external validity. So external validity is generalizability. Who do these study findings relate to? Who can we apply them to, and so forth. And so I should say that all of these, the threats to internal validity and external validity, came from Shadish, Cook, and Campbell, which is sort of the Bible for causal inference. And I'm happy I can email out the reference if folks are interested. But it's a very easy to read book about different study designs and external validity, internal validity, and all the things we're sort of talking about today. I can post it on the website if it's because it's sort of a classic reference. So if it's something you're interested in learning more information about. And so Shadish, Cook, and Campbell talk about threats to external validity or generalizability. And essentially what they talk about is an interaction with the causal relationship. So when they mean causal relationship, they mean X causes Y. So your exposure to a particular program or intervention causes a particular outcome. And so they're thinking about this pretty much in a very controlled environment, classic randomized clinical trial or controlled trial. And so what they suggest is that if that relationship between X and Y differs, if you differ the context at all, that limits your generalizability. So that directly goes back to the fact that, if you don't mind me flipping through here again, this is exactly what we're talking about here. So when we're very, very controlled, that means X causes Y in a very limited setting, right? We have very little applicability here, meaning that if we change when and how X causes Y, we're going to lose a lot of our generalizability. Okay? Does that make sense? Okay. So what they're suggesting is that relationship between X and Y, if you look at different subgroups, so for example, if you are looking at the effect of an intervention on a particular outcome, and then you say, well, we're going to look at younger kids versus older kids, and that's different, that's what they mean by it's limiting your external validity, because now the result only holds true for younger kids. So now you can only say X causes Y in the younger population. Okay? So they're suggesting that that's problematic in terms of who you can generalize it to, because now you have a much narrower population that your results are applicable to. Or over-treatment variations. So let's, for example, say, well, we had a tiered approach where part of the group got a more intense treatment than the other group, and we saw different results. So that means, again, that the results might be only applicable in a setting where the kids can get the intense treatment, and not so much where the treatment is a little more watered down or less frequent. Okay, so it changes who you could generalize this to. So now you're saying our results are only applicable in a clinic where the kids can be seen 3 times a week, for example. You could change your outcomes. You might have a particular outcome like emergency department utilization, but then you suggest, well, let me look at some of the other outcomes like parent satisfaction or primary care visits or maybe some pulmonary function tests, for example. And you're seeing that the emergency department utilization is reduced, but you're not seeing any differences in pulmonary function test or parent satisfaction, for example. So again, that limits what you can say about your results in terms of it's good for a very specific outcome, but maybe not some of these other mediators, for example. Same thing with setting. It could work in, the pulmonary clinic at Children's Hospital, but not necessarily in, for example, community hospitals or rural settings or things like that. So again, it's very, very applied to a very specific population, a very specific niche. Context-dependent mediation is when you have an explanatory variable. So, for example, I use the example of pulmonary function tests. So it could be that you're seeing fewer emergency department visits for some kids and not other kids, and that could be a function of pulmonary function tests. So the intervention could improve pulmonary function for some kids and not for others, and then that relates to whether or not they're going to have differences in their emergency department visits. Okay? So what they're suggesting is that all of these things can be problematic in a very controlled environment. And I just wanted to highlight these for you because if you're in that very controlled environment, then you do worry about these things. But most of what we're doing in outcomes research is not that, right? So Ali talked a lot about the outcomes research being much more applied. It's randomized. It can be randomized clinical controlled trials, but in real-world settings, right? Real-world populations. And so I highlight these even though they're threats to external validity, they're threats in a very controlled setting, when in fact for us, these are things we're really interested in most of the time, right? And this is have you got folks heard of this term treatment heterogeneity? So essentially what treatment heterogeneity is all of these things that I'm talking about. That it might be, you might get different outcomes in different settings with different subgroups, rural versus urban, clinic versus primary care office, older kids versus younger kids. And for outcomes researchers, we love treatment heterogeneity because it can explain a lot of things, right? Because this is the real world, and we are dealing with older and younger kids, kids with high and low pulmonary function values, kids in rural or urban areas. So I present them first as threats to external validity because that's sort of the classic sense of the way we think of them in a controlled way. But in outcomes research, we actually like to exploit these things. And again, it goes back to having a really strong research question and a strong conceptual model or conceptual framework to know what might be of interest. Because oftentimes what's going to happen is you may not find an effect for many of the things we study. You may not find a direct effect. But then when you start looking at subgroups or different subgroups by either age or race ethnicity or SES or location or different biomarkers, that's when you're seeing a lot of your difference. And so this idea of treatment heterogeneity is becoming really popular in outcomes research. And I think it plays nicely to your study design, right? Because you have to, again, it goes into that balance of how applicable do you want to be and to whom. Okay, because we want to be applicable to large, real-world settings, large clinic populations, a whole group of patients, not just a very narrow slice of the pie. Does that make sense? Okay. All right. So let's talk a little more specifically about study design. So just to show you again what our study question and the conceptual framework, we saw this first or second. Seminar. So our exposure is the asthma action plan, whether or not the child has an asthma action plan or not. And our outcome, so this is our exposure, the intervention, and our outcome of interest is emergency department utilization, which hasn't been particularly well defined because there isn't sort of a time frame here on this, but let's just assume, we can choose a hypothetical time frame in terms of when we might be looking at this. And so again, these are the things, are potential threats to internal validity, right? So things that are associated with both the exposure and the outcome. So these are called confounders or threats to internal validity, things we want to measure early on, not only for bias, but if we lose kids, we want to know, well, what did they look like at baseline? So going back to all the threats to internal validity, coming up with this list early on and making sure we measure them well is incredibly important. So things like acuity or severity, compliance, access to health services, SES, or just, kind of a handful of the classic ones. Okay, so our first study design that we could consider is doing a randomized clinical trial, or randomized controlled trial, or a pragmatic trial. And so what I wanted to do was talk a little bit about the difference between those. I think most of you are probably familiar with the randomized control trial, but maybe not so much a pragmatic trial. And essentially, I have another slide that defines it and kind of goes through the strengths and limitations, but I'm presenting this because I thought it would be useful to think about the differences between a randomized control trial and a pragmatic trial. And essentially, it's a continuum. So they aren't necessarily two discrete, different things. They're on a continuum of controlled trials, right? And so this arrow is meant to represent how much control you have over the individual treatment, over the context, and so forth. So we know in a randomized control trial, we have the most amount of control, and we talked about that the first couple of sessions, that you're looking at a very controlled population. You screen people out who have comorbidities, or characteristics that you think might interfere. So essentially going back to this, you screen out these people, most of them, right? And because you're really interested in, does X cause Y in this narrow slice of the population? So you have the most control over all of your contextual variables, your treatment variables, patient characteristics, and so forth by design. And we also talked about how we're in this end of it, right, where we have a lot less control about that because we're dealing with real people, real populations. And so a pragmatic trial falls in this end of the sort of randomization spectrum, and control. So this is the degree of control over the individual treatments or interventions post-randomization. So in both cases, you're randomizing people, okay? It's just how much control you have over how the intervention is delivered and the contextual environment. So I'll give you 2 examples. So you can have a pragmatic trial where you have less control over the intervention. And so this is an example from the adult literature, but it's low back pain. And so the idea is that you randomize physical therapists to implement a clinical pathway related to low back pain. So there's a protocol, there's a clinical pathway that PTs are supposed to implement with their patients with low back pain. However, we know that people have different responses to treatment, and so the idea is you have a framework of how you do it, but then based on individual differences, you might tweak things. So you might tweak some of the exercises or the home program or how often you see the patient, for example, but they're still randomized to this overall protocol. But there might be some slight differences in how each individual receives the treatment is not going to be exactly the same, because that's real world, right? Where PTs aren't robots. We make clinical decisions about patients and so forth. So in that case, you've randomized, it's still a very robust trial, you've randomized patients to receive the pathway, but there's differences in what each individual patient actually receives, which is very real world, right? Can you consider where that would be or see how that might be relevant to work that you do? Versus, okay, so then the more control.
Well, I meant, what's the other, you randomize the patients to receive either?
Oh, so a clinical pathway or just usual care.
Okay.
Usual care, or you can come up with some kind of treatment alternative, like you might have your clinic might see low back patients, 3 times a week for 45 minutes, or do a specific set of exercises. This is, presuming this is sort of an evidence-based clinical pathway, we're going to do these types of exercises, these home program, and so forth.
So the loss of control is the variability of the PT's administration of the pathway.
Exactly.
The randomization is to the pathway versus, ibuprofen and ice.
Exactly. Exactly.
Okay.
So it's the variability of the PT, but it's not sort of random variability, right? Which it could be, but we worry less about random variability because that's just noise in the data. But if I see, let's say you and I are seeing the same patient, and I say, well, I'm going to tweak this home program a little bit. I'm going to follow the pathway, but I'm going to change it slightly to match your individual patient needs. And you do something a little bit different. You're also following the pathway, but our 2 patients receive slightly different therapies. Okay, so that's the control that I'm talking about. Versus something that you have more control of that mimics more of a randomized control trial. And these are the examples that Allie was talking about where she does recall for pediatricians about immunizations. So in her situation, every patient and every provider is actually receiving the exact same treatment. There's no tweaking of the treatment. So for all intents and purposes, this really is an RCT. It's just a community-based RCT. Okay, and she's not, excluding people. It's all all pediatric practices enrolled, all children who attend that pediatric practice, and so forth. So it's a pragmatic trial because it's a real-world setting. But her trials look more like an RCT than this low back pain example one, because all the providers get the same recall, and then the way they interact with their patients is the same. Does that make sense? Okay, so. A pragmatic trial, by definition, we have this idea of randomization. So groups of patients are randomized to a particular protocol or treatment. So in this case, the asthma action plan or usual care. And the level of the intervention is the protocol, not the specific, and it's management, not the specific intervention. But in many cases, they can be one and the same. So for the immunization example, those are one and the same. For the back pain example or the asthma action plan, it will be randomization to the asthma action plan, not the exact what happens between the provider and the patient. So for the example for the asthma action plan, that pediatric primary care practices would be randomized to, the kids would be randomized to receive the asthma action plan or not, or usual care or some other alternative to care. And then you look at emergency department utilization. So the biggest strength of this type of study design is that you have randomization. So you have your threats to internal validity are very, very low. because the idea being that if you think about all those things that we worried about, the threats to internal validity, so SES, access to care, acuity, and so forth, basically what you're doing is randomizing people to your exposure. So all of those differences, in theory, should wash out. And your groups should be what we call balanced at baseline when they receive the intervention. So it doesn't matter that you have some sicker kids, the idea being that the kids with more severe asthma would be randomly allocated to your exposure. So you shouldn't have to worry about those kinds of threats to validity.
Doesn't mean that you do well-designed randomization, right? So like you can't randomize the practices and then have everybody in practice A get, asthma action plan, everybody in practice B gets standard of care, right? You have to randomize, you have to do a good design and how you randomize.
Right, so that brings up a good point about the level of randomization. So there's pros and cons to each one, right? Because if you so what do you think would be a pro to randomizing it at the provider level? Consistency. Oh, sorry, yes, I'll repeat. So consistency, yeah, and so what's going to happen if you're a pediatrician and you're in EPIC and the asthma action plan pops up for child A, and then the next child with asthma comes in and the asthma action plan doesn't pop up, so you worry about fidelity too and bias, but, because there's could be provider bias because the provider knows which group the child is in, right? So if you randomize it at the provider level, then one strength is you don't have to worry about that. But you could worry about the individual attributes of children, right? So you may not have gotten your randomization completely right in that sense. But, so what you have to do, nothing's perfect, right? So you have to weigh those. If you have really good information about the kids, about all the threats to internal validity, you can do checks to make sure that your randomization worked. There's different ways, there's more sophisticated, instead of just simple randomization, there's more sophisticated ways to randomize kids. You can randomize, match and randomize and so forth to get at these issues that you're talking about. But again, it's this sort of trade-off of different pros and cons. So the randomization allows for this causal inference, right, because we're really minimizing our threats to validity. It allows you to do it in a real-world setting, right? So we're talking about real pediatric practices, sort of all comers. We're not excluding kids with real severe asthma or have transportation issues and so forth. So you get internally valid results. And I think a particular strength, not so much for the immunization example, but for the asthma example and the low back pain example, is that you allow this sort of clinical decision making, right? And that individual treatment, patient-provider interaction to vary, right? Which is, I think, the real strength of doing outcomes research, because this is what we do as clinicians, right? And this is what we're interested in outcomes research. And not only that part of it, you can sort of exploit that part of it and measure it, but then if you think back to the things I talked about with the external validity, if there are differences and you are recommending that patients be seen more often, or there are differences across patients, you can exploit that. That's the treatment heterogeneity that I'm talking about, that can be really meaningful and make a nice contribution to the clinical literature and your clinical practice. Because you can answer some of these questions about these very differences that we're talking about, but you're doing it in a very robust, controlled, methodologically sound way. Okay. So some of the limitations, costs. I mean, anytime you deal with randomization and big, randomized controlled trials out in the community in particular, I mean, these are quite costly. The logistics of managing multiple sites, which we started to talk about a little bit, and patient variability. So how are you going to manage those differences? Randomization doesn't always take into account all of those differences. Blinding is difficult, which I suggest if you randomize within a particular practice, the providers are going to know whether or not the asthma action plan pops up. And there could be contamination for that reason, right? So contamination could be, patient to patient. Moms are talking in the waiting room about, what are you talking about, asthma action plan? I don't know anything about an asthma action plan. What do you mean? Oh, you saw this particular person, or you received this, or providers talk to each other. That's the kind of thing that you worry about that happens all the time in the real world. And so that's the importance of knowing about these things and measuring them. So going in and, maybe doing some staff interviews or kind of figuring out how much this may have played into your results. So again, it's not a fatal flaw, it's just something you need to be thinking about and know about. So quasi-experimental design. A quasi-experiment lacks random assignment, but otherwise is very similar to an RCT. So, for example, it could or could not have a comparison group. Pretty classic examples are when you exploit some kind of variation that happens in the outside world, and it's sort of this is also called a natural experiment. So you have sort of a pre and post group. So an example might be if Medicaid said, for all kids in asthma who have asthma that are enrolled in Medicaid, providers, you need to have an asthma action plan for them. Okay, so that's a mandate. It's a state mandate. So now all of a sudden, you have this group of kids that, in theory, should have asthma action plans, and you had a group of them who did not. So if you knew this policy was coming, you could measure the kids who didn't have the asthma action plan and compare them post-mandate to the kids with the asthma action plan and look at emergency department utilization. So they call it a natural experiment because it's some kind of policy lever that happens or something that happens contextually that you can sort of use to your advantage. So it could be, not a policy example might be there was a new program that was developed where everybody who came to a particular clinic or a particular hospital would get an asthma action plan, and it was sort of outside of your control, and you decided to do some measures pre and post, or post and then go back retrospectively and look at the characteristics of kids who didn't have the asthma action plan. So it has the properties of a randomized clinical trial in the sense that this was the exposure. So when we talk about randomization, it means that the allocation of the exposure was outside of your hands. Okay, so that's good because then you have nothing to do with it, and so there weren't biases in terms of who got the intervention. So the same thing happens with a natural experiment. Who gets the treatment is beyond your control. It's something that happened, either a program or a policy and so forth. So the extent to which that's true, then you can exploit that, and so it can potentially give you properties of randomization. Again, in a real-world setting, so it's real patients, especially the Medicaid example, because it's real Medicaid enrollees and so forth, and in that sense, they're internally valid results. The limitations is that it's often difficult to find that what we call a policy lever or program, something that happens outside of your control that then you can use to do pre and post measurements. So it could be the feasibility of actually implementing it might be tricky because in some cases you might not have baseline information. You have to go back and collect it from chart reviews and so forth. And so again, it's this balance of the internal and external validity and how generalizable your results might be. So somebody asked about what I meant by program evaluation. So the definition used in literature is the use of one or more research methods and assessing various types of a program or policy, including its components, operation, impact, and generalizability. So we've talked a lot about impact. So impact just means its effect and its generalizability. What's different about program evaluation from the other methods that I mentioned is looking at these sort of components and operation. And so this is becoming a really hot topic in terms of how interventions are delivered. And it goes back a little bit to the pragmatic trial example, but oftentimes the way we think interventions are being delivered are not often the way they actually are. So going back, and so if we don't know that, and we might be very confused about our results. So there's a big push now for sort of the fidelity of interventions and understanding what's really going on. And so this is where a program evaluation can be, or components of a program evaluation can be really useful. I consider these sort of process evaluations, but which kids received which kind of treatment? How was there contamination among therapists or providers or among families? Those kinds of things, sort of the behind-the-scenes things that end up being really important at the end of the day in terms of the fidelity of the treatment. And essentially, so the application would be you're evaluating the association of an asthma action plan on asthma-related ED visits. So here you're using a mix of quantitative and potentially qualitative results. You may interview parents, you may interview pediatricians, and so forth. You might have a long list of other outcomes besides just emergency department, so metrics along the way, process evaluation, program coverage, cost benefit, cost effectiveness, analyses and so forth. A particular strength is policy relevance, because, particularly if this is, like the mandated example with Medicaid, asthma action plans, and so forth. So these results are, very generalizable and directly applicable to new programs and policies, influencing future program design or program design at different sites. A limitation could be generalizability. If the components are very program specific or staff specific, then you might have a harder time bringing it to a different clinic. You might have to tweak the program a bit to have it, applicable in a rural setting or a different clinic, for example. There's lack of randomization, right? This is just a program evaluation. You're not, in this strict sense, you're not randomizing people. There's certainly ways to combine these study designs and have a randomized component, and then you're really strengthening your validity here. And financial and time considerations, for any of these programs. So a cohort study is when you examine a specific population and you follow them over time. Sometimes these are called longitudinal studies. And you look at specific populations or subgroups by age, hospital discharge, insurance coverage, and so forth, as they change over time. So a prospective example, you might follow asthmatic children, and then whether or not they have a care plan, follow them and see who goes to the emergency department within the first 6 months for asthma-related visit. You could look retrospectively, so you have it, and that would consist of a chart review. So if you have an asthmatic group and you go back in time and see, well, who had an asthma action plan, how many times did they go to the emergency department, and so forth. The biggest threats are internal validity threats. But if it's prospective, you can track some of these things, and we've talked a lot about that, measuring these covariates and making sure you measure them well, and that again goes back to the importance of your research question, because the more you can measure these things and control for them, then you'll boost your internal validity. A limitation is, unfortunately, probably not for this population, but it can take a long time for your outcome to occur. So you may be waiting months or years for, if this is sort of a rare outcome, which is not the case here, but in some of the clinical examples that you all are interested in, you might have to wait a long time for it to happen. So having a group that already has the outcome and then looking backward might more of like a case control study might be more desirable. And I think, okay, so this is the last one. So survey research is a systematic method to collect data directly from respondents regarding facts, knowledge, attitudes, beliefs, and behaviors. So probably already just in seeing those words, you can see the difference, the strengths of that approach over, for example, a program evaluation or a clinical trial where you're just looking at emergency department visits. Again, not to say you can't combine components of this. You could have an RCT where you incorporate a research, a survey research principles to it, or a survey. These are not, mutually exclusive study designs. But this, a strength of this is you can get some deeper information about, particularly about parents' attitudes and knowledge about asthma and their beliefs about bringing the kids to the emergency department versus primary care, and, get at a lot of these mechanisms which you might not have any idea exist about stigma and cultural differences and so forth. So it can be cross-sectional, so you can do a one-time survey with families and just ask them about, do you have an asthma action plan? How many times have you been to the emergency department in the last 6 months? You can use trend data, which is essentially repeat cross-sectional. So you might do a survey, survey over time. And trend data isn't necessarily the same people over time, but you're essentially looking for trends. So what proportion is the proportion of kids with asthma action plans, is it growing? Okay, if you do a survey every year, are the emergency department utilization, is it declining over time? Not necessarily the same kids over time, though. Panel or longitudinal data is when you have the same kids over time and you're giving them the same survey. So then you can really say, these are the same group of kids, and in fact, ED utilization appears to be down for asthma-related visits. So an application might be, creating a survey. So designing and implementing a survey that asks questions about asthma action plans, ED utilization, and so forth. And you might want to ask a lot of other questions that would allow for a richer inquiry. So things around attitudes and beliefs and behavior and so forth. So the biggest considerations here are really how you're going to administer this. Are you going to do it face-to-face? Is it going to be a mail survey? Is it going to be a web survey? So all of those have different, you can imagine time and cost constraints associated with them. It's very expensive to do a mail survey, much cheaper to do an internet one. Meeting face-to-face is obviously more expensive than over the phone. Piloting and testing the data survey are really important and steps often people don't consider, because what you don't want to do is send out your survey and you have a bunch of bad questions that parents aren't going to understand, and then you get back the data and you have no idea what to make of it, when that could have been remedied in the beginning by just piloting it to even 10 or 15 parents of kids with asthma. Sample size and response rates. Historically, survey research, a good response rate is like 57%, 60%, right? So if you're thinking you're going to get 90 some odd percent, it's probably very unrealistic. And so who responds and who doesn't can be problematic. I think we've highlighted some of the strengths. It can be really efficient, get at questions that just administrative data can't answer. You might not have incorporated into your program evaluation or a clinical trial if you're focused just on clinical outcomes. This can give you really rich information about patient experiences and so forth. Some of the limitations are really designing and, piloting the survey and really getting it out into the field. The data are, by definition, self-reported, so you could worry about differential bias there and how parents remember things. If they're systematically remembering things differently, then you worry about that. Depending on how well you pilot it and create it, it could be a lot of money and a lot of time for very little scientific yield. So that's why the importance of really figuring out what you want to ask and incorporating it into your design at the forefront is really, really important. Because I'm involved in a survey now of the special needs program at Children's Hospital of Wisconsin, and it took us about 1.5 years to get the survey out into the field. And thankfully, we're working with a really smart group that has some really wonderful questions, so the scientific yield will be hopefully very great for us. But had that not been the case, it would have been 1.5 years, and I would have had very little information at the end of the day. It's very incredibly time-consuming to do survey research and to do it well. So that's my only caution. You'll see next week in the secondary data, or 2 weeks, the secondary data analysis. I'm very pro survey research, but it is definitely a lot of work, and you want experts who know how to do it well. All right, so unfortunately we're out of time here. So we'll start the beginning of next session. We'll take just a couple minutes to kind of walk through some of your examples and think about study designs and so forth. But I'm happy to stay for a few extra minutes if people have questions. Thanks. Yes. So no meeting next Monday. Hi.
That was very good. Thank you.
Sure.
I'm